think we're going to move on to our next speaker just because of time in the program. It's Dr. Valerie Elmalem from Mount Sinai. The doctor says my optic nerves are damaged.
Thank you, everyone. So we will be presenting normal vision and thin RNFL. I have the following financial disclosures, none of which are relevant to this talk. So we have a 56-year-old man who presents with headache, and he was initially referred because of an abnormal OCT. Past ocular history includes moderate to high myopia and vitreous floaters. Past medical history includes hypertension, hyperlipidemia, and asthma, and these are the following medications that he is taking. He has normal visual acuity with correction of 20/20. You can see his refraction, normal color vision in both eyes, and as well as confrontation visual fields. And pupil exam revealed equally reactive pupils without any relative afferent pupillary defect. Ocular motility is full. Anterior exam only shows trace nuclear sclerotic cataracts. And here is his fundoscopic examination. I'd like to invite the panel to comment on the appearance of the optic discs.
This is the dreaded abnormal OCT with funny-looking discs. And they're tilted. They have some parapapillary change that makes it difficult to establish the edge of the nerve and how you're going to center the circle on the nerve. And there are a lot of artifacts, which I'm sure we're going to go into, based on this kind of problem.
So buyer beware, right? Tilted nerves, moderate myopia, and this is what I was suggesting earlier, that alone will thin these measurements.
So this is what the OCT shows.
Okay, great. So one important part of this report that a lot of people don't pay attention to enough is the disc area. Remember, the OCT also segments where Bruch's membrane ends, where the neural canal opening is. So how small or big is the disc area? And those discs on that fundus photo looked a little small to me. And the OCT here kind of helps also say that. The normal disc area is about 1.8 millimeters squared. The other aspect about this scan is what glaucoma specialists call the dreaded red disease. And the reason is on the probability plot, there's a lot of red pixels there that say, oh, that's abnormal. But if you look at that nerve fiber layer scan, the middle one, the T-SNP plot, you'll see how the peaks are displaced away from where the normal peak should be on the green part. And that's very characteristic of a myopic long eye. So those peaks are in the wrong place, and that drops the other part of the nerve fiber layer on the probability plot into the red area. So it's an artifact of sorts due to myopia. In addition to that, this person has small optic nerves, so they were born with a little bit less axons probably. So I would say that this is a combination of what I would call false positive OCT for all those reasons.
Would having a ganglion cell complex analysis help you in this situation? If you had the retinal ganglion cell complex analysis, would it help you in this situation?
Well, the problem that Dr. Rizzo brought up is with long eyes and thin retinas, the normal probability plot may be distorted. So you may have some what looks like some ganglion cell layer thinning in a myopic eye, but it's so it can also mislead you a little bit.
And I think it does routinely, the ganglion cell segmentation at the macula routinely misleads you with moderate myopia.
So I'll provide a little bit more information. Here are the visual fields, which is essentially normal. Maybe there's a little bit of infranasal changes in the left eye. On to our ARS question. The next step would be to obtain an MRI of the brain in orbit since the patient has signs of atrophic papilledema and also complains of headache. Initiate a workup for bilateral optic nerve hypoplasia. Repeat the OCT since the scan quality is poor, or observe. Good. Got it right. Okay, so I provided a little bit more information on the OCT. The panel has already commented on a few of the components of this abnormal OCT. Can you just make a few more comments based on the additional information?
I don't think there's anything more to
Okay.
say.
So I'll just go over the average RNFL thickness overall. In the right eye was 84, and in the left eye was 83, which is not really significantly thin, even though you're seeing that there is apparent significant thinning superiorly and nasally in the right eye and nasally and inferiorly in the left eye. You can see that the disc area is 1.28 in the right eye and 1.21 in the left eye, which is low. So there are small nerves. Other things to look at on the OCT scan, you want to look at the signal strength to make sure that the scan is obtained at a good enough quality. The signal strength should be 7 or better. And also look at the RNFL thickness map and the RNFL deviation map, which are located in the upper outer corners on the OCT. Visible artifacts will look pixelated, or you might see a black line going through the scan, so you want to make sure you don't see that. And also analyze the RNFL tracing on the circular tomogram to make sure there aren't any abnormal peaks or valleys and that it's following where the RNFL should be located. And then on the scan, just to indicate that this is a patient who has a myopic tilt, you can see on the center of the OCT that the disc does look a little bit tilted, and as they discussed, the peaks on the circular tomogram are more widely spread apart because of magnification effects on the OCT. The OCT detects that the eyeball is longer, and this will result in an artifactually low disc area. And the other factor that's different in myopic patients is they have slightly displaced RNFL temporally, and this follows the superior and inferior arcade, and this gives apparent superior and inferior thinning on the OCT, which is artifactual. This is the area where you would see that. The 5-line raster is also helpful in looking at the configuration of the optic nerve. You can see that in this case, the angle of the disc is tilted compared to the normal inferior diagram. And the other thing you want to look at on the raster images is the insertion of the Brooks membrane. So in a normal disc, the Brooks membrane should have a slightly downward configuration or neutral, whereas if you have a patient who has raised intracranial pressure and papilledema, the Brooks membrane will have an upward displacement. So in a patient who has a funny looking nerve, who complains of headache, this is also a useful scan to look at. Just wanted to ask the panel, how reliable do you think this finding of the Brooks membrane is in practice?
I think it's more reliable for following the course of someone. If you take a large group of patients that have bona fide raised intracranial pressure and papilledema and look at the angling of Brooks membrane, there's a distribution. And some of them are almost neutral, and some are displaced towards the vitreous. And so if you just look at one scan on one patient that comes in the first time, I think sometimes it isn't that helpful. But if you're following that patient, if they're being treated, and you start to see that starts to displace backwards to the normal configuration from where it started, that could be extremely helpful to know that you're going in the right direction.
And also, I just wanted to comment, we don't have several scans here in this case, but in a funny-looking nerve, the other helpful OCT that you can obtain is enhanced depth imaging, which can be useful to look for optic disc drusen or any structural abnormalities of the optic nerve.
Going back to the Brooks membrane complex, in the terms of the orientation, how quickly do you think that changes, and does that help you in your management of patients with papilledema?
So a number of people have studied that. Heather Moss has studied it, Mark Cooper-Smith studied it, Pat Siboney studied it, and for example, right after a lumbar puncture, half an hour later, you'll see some changes in Brooks membrane. Is that right, Heather? Yeah. So it happens very fast, whereas the retinal nerve fiber layer thickness may take a week or two to start changing. So that's where it's very helpful to see if you have a very early good sign that things are starting to go in the right direction.
So Randy, you talked about how the tilting leads to the shifting of the retinal nerve fiber layer peaks. Does that not also have an effect on the measured disc size, number one? And number two, would you use the OCT as an indicator of a small enough optic nerve to indicate optic nerve hypoplasia without clinical signs?
Yeah, so that's a good question. If you look at the range of disc area, some of the disc areas are really small and they have normal visual fields and nerve fiber layer that's still in the normal limit. So I think you can still have, and it depends on what's your definition of optic nerve hypoplasia. Do they have to have visual field defects too? Do they only have to have a smaller number of axons? So it's kind of a slippery question. It really depends on how you define optic nerve hypoplasia.
Well, I think as adult neuro-ophthalmologists, we often see patients who are incidentally found to have optic nerve hypoplasia without systemic findings that are often seen in the pediatric population, and it's just there.
Yeah, I agree. I mean, they're often come in with visual field defects. That's why they come to medical attention, and it's not recognized that it's segmental optic nerve hypoplasia.
Or they may present with asymmetric discs with more of a nasal tilt on the side of the optic nerve hypoplasia and be thought to have papilledema.
Now, the other way that people use this in their practice, especially general ophthalmologists, let's say you have a patient that comes up with asymmetric cupping. So one eye has a 0.5 cup and the other eye has a 0.3 cup, and you're worried about, is this a glaucoma suspect? You can use this disc analysis because usually with physiologic cupping, the eye with a larger cup has a larger disc area. There's more room for all those axons to go through there. And so that's where this analysis of the disc can be very useful in your practice, is differentiating physiologic cupping from acquired cupping.
Just go to the summary for our discussion. So there are several factors that contribute to an abnormal OCT of the optic disc and normal vision. So there are anatomic factors, such as in our patient who had small, crowded, tilted optic discs with moderate high myopia, which can lead to artifactual thinning of the retinal nerve fiber layer. Other structural abnormalities, such as optic pit, a large disc, as you mentioned, optic nerve hypoplasia, optic disc drusen, and sometimes prior papilledema with gliosis. Mild damage to the optic nerve, such as in early glaucoma, preparametric glaucoma, healed optic neuritis, or an old traumatic or compressive optic neuropathy, can also have abnormalities on the OCT but normal visual fields. And you also want to look at the OCT image acquisition artifacts, looking at the signal strength, the tracing of the retinal nerve fiber layer, and looking at that circular tomogram to see if it makes sense. And you always want to compare your clinical history and your examination findings and ask if the OCT correlates. Thank you.
Very good.